because we might have fixtures. Maybe you have the parasite, the mycosis, and then general think, and you're done with infectious. Wow. Yeah, that's difficult. I don't know why they do this. I really don't know why they do this. Seriously. This is not what will make them be a better physician. Far away from it. This is where they're not good physician. It's all about the lab and research. That's all. Okay, so did you thought about what you want to do next until you get a result and see what happened? Because after that, when you get a result, I guess it will be you and me. I will just we will just go over questions by your step. Because so far, embryology, molecular biology, these are stuff that okay, we can let me take note. We can go over physiology, pulmonary physiology. What else? You know what? Think about the list and send it to me. And that's how we're going to do. So next, when we finish with the infectious, we're going to do physiology, pulmonary physiology. Yeah. Because, okay, that's good. Okay, so parasitology. Come back. Oh, the computer has maybe it's memory issues. So we went over the bacteria, the viruses. Next time is going to be the fungi. And so for now is all about what is parasitology. So think of them as a worm, different type of worm, and some of the worm are BNICDs. Some are going to lead you to septicemia or transmission through blood. Some are going to stay in the liver, for example. Some are going to stay in the lymph nodes for a long time. Some are going to stay in the GI, like the helmet usually. The flukes, this one is mostly the liver. And some are not, the like prion, are not nor parasitic, nor fungi, nor bacteria. They are just proteins that kills. So or anything that is parasitic, obviously, you put it under protozoa. The big one are called helminths, and the smaller one are the mostly that come from the nature arthropods. Um, so if it's metazoa, it means you're going to have they're big. You're going to have multiple section in these. It means multiple cells that to have eggs more commonly, and helminths itself, it's about these type of worm that do have that. That's what you're going to cover. Some of these protozoa are going to be single cells, and so like this one is pretty much re-ask. that you can find mostly. You can find in the OBGYN areas, like the genitalias, vagina, for example, or you can find them in the blood or the intestine. And most of the protozoa are the one that are going to give you malaria, plasmodium, and multiple type, leishmania as well. There's multiple type, antimeba, which give you bloody diarrhea, trypanosoma, toxoplasma that love babies and HIV patients and leave scar calcification in the brain, and the Zardias. Do not mix up Zardias with antimeba. Sometimes these two can be mixed because they might look like the same, and the way of transmission will be almost the same. So I see multiple classification for these protozoa. We're going to go over the most common one, most important one for all these ones. But also you can classify them by the region where you're going to see them, either the brain, the viscera, the blood, the sexual transmitted one, or GI. Remember, GI is going to be the biggest one because uh, direct transmission, and they're going to stay there forever until they start to go through either lymphatic or the blood. Most commonly is going to be the blood itself, and anything that is within GI, they're going to feed on the people food, and this is why sometimes they have diarrhea plus they don't gain weight. So these are the ones that are going to be mostly in the lumen within the GI itself, and some of them give you diarrhea, some of them do not, and the way where you're going to find them are going to be to give you the different type of symptoms. So some of them are super high yield, some of them are not as high yield, but this is an exam where they give you anything. So the antimalarial celestica, for example, or omebia, this one you need to know it very, very well. And remember this as well goes with travelers type of disease, and which can give you two things: can give you the dysentery in this abundant diarrhea, and it can give an abscess, a liver abscess. And actually, the liver abscess is going to be a bit different. It can be unique most commonly, or it can be multiple type of abscess, depending on the severity of it. And the more common question are going to be travel. They go to Mexico and come back with this disease. Remember that these are going to be part of the trophozoid family, and the way that they move, this is what give it this type of family. Either they move with flagella or they move like an amoeba, like the macrophages move the same way by changing the cytoplasmic membrane structure, and then they start to move. So the second one, which is the Balantidium coli, this one is not as high yield as Amantemeba stereotica. This one is sedated and give you colitis. The Neglia fowleri, this one is kind of high yield. There's multiple questions about this. Why is because this is something that give you meningoencephalitis, and they're going to have flagella, the same thing, and they are part of the amib, part of the other Balantidium might look like that. The Xanthomeba, this one is high yield as well. Same deal. This is two location, brain plus eye, and usually give you inflammation. And this part of the trophozoite as well. The Giardia lumbia, very high yield. This one give you direct disease and malabsorption. And the differential diagnosis would be the Antimeba stereotica. But remember, this one do not give you liver abscess as the Antimeba would give you. So this one is the order of the Mastigophora. Usually, the order and stuff that might not give you as questions. If they give you, maybe it's one rare questions. But just remember the clinical presentation plus clinical presentation and the name of the parasite and the location and how you can get this parasite. So the pathway of how to get infected. Those are big questions. Um, and just remember, this is also a question that you can have in step two as a microbiology type of questions. This is a material that you need not only to master for an exam, but master for later. Um, so the isospora belly, this one give you current enterocolitis and also give malabsorption like the giardia. The same deal. The only thing with this one, this is with the family of coccidia, meaning they're from eggs. You don't see them as oocytes. This one as well is not as high yield. The cryptosporidium, this one is high yield, and why? Because HIV. And then you're going to have one that is a trophozoids as well, and you can find it in vagina. So the Trichomonas vaginalis with the specific odor. Um, the Trichomonas vaginalis can be part of the flora, but if the amount of it is not that big, it doesn't cause much problem. The problem starts when a woman takes antibiotic, for example, or a douche and they lost the natural flora, then Trichomonas vaginalis can expand and can attack the urinary system plus the vaginal system. The other one, Plasmodium species, this one you need to know it very well, and that is by blood. So we call them hemosporidia. So there's many of them, and the disease is the malaria. So understand how the typical fever of malaria, that is the typical thing, which you're going to have pick of fever and chills. The Babesia microti and the bovis, especially the microti, this has been asked in the board, is almost like plasmodium, and it's going to give you the babesiosis. Treponema species as well, high yield, and that is give you by the tsetse fly, give you the African sleeping sickness, where they're going to sleep nonstop. And this is the differential diagnosis with the what is the other condition that makes the individual sleep? Yeah, narco, yeah, narcolepsy. The only difference in here is the people that are having the sleepy disease sickness usually come from Africa or are there, and as narcolepsy, they have this for a long, long time. And the people that they have sleepy sickness without treatment, they die. Then you have those that are a bit complicated to treat. That are super high yield. These are intracellular type of parasites. So you have multiple of them. Trypanosoma cruzi, Chagas disease, super high yield. Remember Texas. Leishmania donovani, super high yield. That give you Calazar with the big spleen. Leishmania species in general, that you're going to have the cutaneous one, and beside the one they give you Calazar. And then you have Toxoplasma gondii, give you toxoplasmosis mostly in kids and or in fetus and HIV patients. These are the two big category of people. Then you're going to have what are the arthropods. Arthropods are mostly insects that you're going to find everywhere. Some of them can be high yield. Some of them are not as high yield, and most of them are you need to know. What you need to know is simply because in practice you might find people that has been bitten or having the symptoms of the bites of these arthropods. Coming from lice, bed bugs, fleas, and remember, bed bugs. If a bed is contaminated, you just throw away the bed. You don't cannot do much about it. The fleas, the mites, and the ticks, and then you have all the spiders, the arachnoid ones. The spiders, the enters of spiders, the bite and the necrosis that they're going to form. Some of them can be pretty much deadly. So here an example of scabies that is in the skin, and one of the things is it leave a line, and this line, this is where they're going to lay the eggs, and you don't see as many conditions now as it was before, but still in poor areas, poor hotels and stuff, you can find them. So, as we saw earlier, the different type of protozoa that you're moving. So now the STDs that come from protozoa. So remember that these classification are part of organ infected, and Trichomonas vaginalis is one of the STDs protozoa that were infected. You know the picture for it because this is one of the picture that is high yield that you're going to have all the time, and sometimes you might see them as smiling, but otherwise you have a nuclei and you have a kind of flagella that comes up from it. And usually when they go in a circle. Um, so Torquenos vaginalis, we did talk about it in OBGYN. We gave you a vaginitis, but also urinary infection. It's the typical thing is about the smell. It's a foul type of smell, and like a dead fish. And you're going to have a discharge that is kind of greenish discharge, uh, but it depends how much infection they have. But because it starts kind of whitish and then become greenish, the big keyword beside the smell is going to be the strawberry color mucosa. That is going to be very red in color. That is very characteristic, and it's super itchy that condition. But itchiness, vaginitis itchiness can be from Candida albicans, which is pretty much very common. But Candida albicans, you don't have this greenish discharge. It's going to be whitish discharge, like a cheesy type of discharge. So this is a disease that is sexual transmitted. Male usually do not have much of symptoms when they have it. Time to time, they have maybe a redness, but other than that, not much. And this is something that cannot survive outside the body. This is what I said. It's part of the normal flora, but the quantity of them are very limited. These are type of protozoa that cannot make eggs or cysts. So this is why they cannot survive outside. And usually the diagnosis is made by looking at the protozoa itself. This is why I said you need to know the picture about it. This picture, for example, there's two or three that might look like the same, so you need to be aware of it. And these are usually organisms that move around, that don't stay stick. One of the keyword as well as the description in your case, they can tell you corkscrew appearance because the way that they look like a circular motion. And the best treatment for it is going to be metronidazole. Obviously, you need to treat both both partners. And remember, the other differential diagnosis beside the vaginal mycosis is going to be Gardnerella vaginalis. And Gardnerella vaginalis, it's a bacteria, which is gram-negative bacteria. Contrary from here, this is a protozoa. In this case, you have a 33 years old woman that presents to the emergency department with fever, headache, and left eye swollen for 7 days. 2 weeks ago, she returned from a 3-week mission territorial of Mexico. Past medical histories are remarkable. She denies any history of trauma, chest pain, edema, diarrhea, dysphagia, and the vital signs were stable. The examination revealed the left eye parietal edema, orbital rim edema, erythema, but no discharge, which the discharge would be important here. The right eye was unremarkable. Both pupils were equal and reactive to light. Extraocular muscle movement were intact. She was presently treated for peripheral cellulitis, but responded poorly to antibiotics. The white were 6,000, and the blood and eye swab culture were negative. Chemistry negative, EKG normal, but there was a low voltage in EKG, and echo revealed diastolic left ventricular dysfunction, dilated left atrium, and ejection fraction of 60%. Peripheral blood smear revealed amounts of T. cruzi. So this is a typical presentation of the eye. Be careful for this type of picture. What will be, give me two differential diagnoses. Pink eye, okay. I will not think about this. Pink eye or obstructive scale of the canal of Schlemm. Okay, conjunctivitis. Be a bit more specific. Look at her eye. The only difference in here is it's unilateral. So, no. You might think about allergies, you might think about angioedema, you might think about nephrotic syndrome. Because the other eye is not red whatsoever. Yeah, that is one side. That is what makes the differential diagnosis. If it was both sides, you might go further in the investigation. But in here, you have clinically, you have multiple things that tells you it's T. cruzi, especially the heart, low voltage. So Trypanosoma cruzi, this is another picture of the bugs and of the parasite that you need to know. Remember, this is one of the bugs that we call it the kissing bugs, um, and because sometimes you might have the area next to the mouth kind of ulceration there. So the most commonly one that you're going to talk about is going to be the American trypanosome. So which the one that give you Chagas disease. So the case that we have, it's typical Chagas disease, especially with the heart issue and the eye. And the Romana sign is the sign of one edema of the eye that should be red, like in here and here. See, redness and edema of the eye that almost shut down if it's not completely shut down. So it's so this periorbital swallowing, as we call it, is not painful whatsoever, and it's pretty much early in the disease. This is why you have suspicion. If you see this, you have the biggest suspicion that you're talking about trypanosome cruzi. Um, so the you're going to have an area that is going to be hardened, like I said, kind of restoration, but very hard. This is where the bug bite. And so you're going to have two phases. One is acute, one is chronic. The chronic one, this is the one that will have cardiomyopathy developing with arrhythmias and low voltage. And this is where you're going to have all the mega things: mega esophagus, mega colon, cardiomyopathy, mega heart. As the acute phase, this is where you're going to have a flu-like syndrome with lymph nodes, and in that situation, you're going to have tachycardia happening, and you might have CNS involvement, but it's going to depend. So once again, kissing bug. How you make diagnosis? Obviously, you need to see the smear, the blood smear, and see the parasite over the place, which we call the triple mastigotes, which is this mobile type of thing. Uh, that be careful. It look like the same. If you look at it, it's going to be almost the same as this. The only thing is with the trichomonas vaginalis, they are round, and usually when you see the smear, obviously the location will be different, but when you look at, it's going to be with the nuclei in the middle, so can be slightly different. But when you look at it on electron microscopy, it might look like the same. But usually they will not give you microscopy. So one of the picture would be this type of picture. Know it, really know it. This is a high yield type of picture. So xenodiagnosis. So you need to make the bug growing, and then you're going to analyze it later. But by the time you analyze, it's too late. So this is why the really diagnosis is going to be clinic, where they come from and the way how they're going to grow. And you can do the smear and you might see it under a microscope. These are the big things. So there's two treatments, nifurtimox and benzimidazole. Remember these two treatments, the high yield. Um, One way to, if you want to remember it, is cruising in my bands with a fur coat on, benzimidazole. Or how you can remember the different sign and presentation, which this in our case they didn't have everything beside the heart, so it means that is a chronic phase. It's more carib, carbon C in Spanish, and remember megacolon, megaesophagus, cardiomegaly, arrhythmias, the bugs, which is this one. Also, sometimes it's asking questions. The kissing bugs is called the Rudevid bug, and the Romana sign, and benzonidazole and EKG changes. So typical bugs, see with the long, but I think also it depends on male and female, and the size can vary as well. And to see here how many bites they receive, and usually the bite can be around the mouth, most commonly with unilateral edema. Other than that, you don't need to know the specificity about the parasite besides how they look like outside. See one eye. Most commonly, the in all cases, all the picture when you look at them, mostly they are on the right side. But don't be fooled; it can be both the left or the right, but is unilateral. So that is the Romana sign. Sometimes you can end up. This is a shakoma where it has been bitten by the bug, and sometimes you might have hepatosplenomegaly as well as lymph nodes in the same time. Usually, this is a disease that is going to stay something like 8 weeks max, and but there's some people that die, especially heart issues. So know the pathways. So you have the bug that is going to bite in the saliva. You're going to find the triple zone inside it, and then you go to the blood, and it starts to multiply. Some of it goes to the muscles, and this is how they start to divide and being released, and you're going to find it again and again in circulation. And this is why you're going to have it in the heart and liver, because this is where they're going to divide. Any area where there's muscle like the esophagus, like the GI, smooth muscle or cardiac muscle, this is the muscle that they love to infect. So remember Chagas disease, which is super high yield. So once again, multiple bacteria. So you're going to have multiple trypanosoma. The one that give you Chagas disease will be the American one. Otherwise, you're going to have the Brucei one. You're going to have the Cruzy one. You're going to have the Rhodosian one. You're going to have the Gambian one. The difference between them is going to be the flagella and the size. Otherwise, you see the Cruzy one do have a head, as the Brucey one do not, to have a very small head. Here, Cruzy, very big head. And the here you have kind of the see the head with the Cruzy. That tells you it's Cruzy. This type of question about the differentiation between the Gambesian and the Brucey or the Cruzy is a question. And how you're going to make the differentiation, the symptom might be looking like the same. The only difference is they're going to put your picture, and through the picture, this is how you're going to make the differentiation. Careful, because this is really very important. Obviously, you're not going to be microbiologist, but you need to know how they look like. So, what are the bugs that are going to affect the CNS? There are four of them, and the trypanosoma is one of them. But you notice that the cruisy one is going to go where smooth muscle are going to be. The Gambian one and Rhodesian one goes mostly in the brain. That is the other differential diagnosis. Keep that in mind for some questions. And sometimes the questions are straightforward, sometimes they're tricky. And you need to make this is a keyword for you. CNS, the Gambian and Rhodesian, cruisy, smooth muscle and heart. The other that are going to affect the CNS toxoplasma, as you know, the Negeria flori as well, and the Acanthamoeba that are pretty much invasive everywhere. So the Rhodesian, you don't have the tip, just like parasites, as you know it. Look like kind of horsey, the head of it. And also the differentiation is going to be the bug that is going to transmit it. Then you're going to have the differentiation between them as well is, you see here you have two names, but in reality, you're going to have the Gambian one is going to be called the West Africa, and the Brucey one is going to, or the Rhodesian one is going to be called the East Africa. I'll put you the information in here. So the difference is going to be obviously the looking of the bugs that are going different. See here the nuclei, what look like nuclei, will be in the middle for the Rhodesian one, and it's going to be in the tip, mostly in the tip for the Gambian one. And the Gambian one is a bit thinner than the Rhodesian one. This one is going to be mostly the Gambian one. So the other difference between them is when the West African one invade. I remember the Gambian one or Rhodesian one. This is why you, because attacking the brain, they're going to give you sleepy disease, and but the difference between them is the amount. See, the West African one or the Gambian one, you have just one. The East African, you have many of these parasites. This one are more fragile. They cannot live in the lab. inside the animals. These can live without any problem. Once again, this is a drawing that I did, and you see the nucleus is mostly posterior. So reservoir, that is going to be the goat, the cattle, and pigs. This one, it can be any wild animal can be given to it. The flies that they're going to give, you see this. There's two type of flies. Uh, the question about the flies is not as common, but you're going to have the G. palpalis and the G. morsitans for the East African, palpalis for the West Africans. Um, so any of them are going to be transmitted obviously through saliva, through the flies, and the fly goes on these animals, and they get the parasite and then give it to humans. So this is the one that we call this what the Chagas would be the American, and the sleepy disease is going to be the African, African trypanosome. Um, so the presentation of the sleepy disease, obviously by the name, I don't know if you saw people having the disease, but these are people that are going to sleep all the time. They're very skinny. They will have fever that comes and goes, and those are depend on the obviously on the load that you're going to have. Besides, they have lymph nodes, and the big problem, differently from Chagas disease, they can die from cardiomyopathy and arrhythmias. As in here, they since it affects the brain, they go to coma and they die from that. The transmission is going to be through the flies and salvia, and this type of fly. Uh, Here you have the typical name. The overall name is a tsetse flies, which are very small type of flies. But most commonly, if they ask you about the vector, um, they're going to use the term tsetse. It's easier to remember tsetse than to remember the typical morsitans and stuff. Um, the other difference with the Chagas disease would be mostly painless as the bugging. As here, they're going to be painful when they bite. Um, so diagnosis obviously is going to be to see the parasite on microscope. So I'm saying to you to know the name. Sometimes you might have these type of questions are rarer now than it was once, but they can give you time to time. I do that question. Give you multiple type of picture and tell you which one is associated with the disease of these patients. Um, so this is why it's imperative to know the picture, or they give you the case and they put your picture next to it, and it's up to you to recognize it. But once again, do not waste too much time. If you don't recognize it the first time, don't waste 6 minutes just looking at a picture. Either first time you recognize it and you move on, or you don't recognize it and you still move on without wasting time. So the treatment here is specifically because in the acute phase the CNS is not affected, but then the CNS starts to be affected, and suramin is going to be one of the treatment of choice because this won't go through the brain barrier. And in a chronic situation, you're going to give melarsoprol as the treatment of choice. Toxoplasma gondii. This one is super high as well. Remember, specifically fetuses and HIV. The characteristic of this bug or this parasite is it's love the brain. So usually it's transmitted through the cat or for pregnant woman. But other than that, remember I gave you the one of the path. Um, if it goes out of its pathways, then it's going to infect the rats. And when it infects the rats, it goes to the brain of the rats, and the rat presents itself to the cat. And by eating it, it's going to be affected again, and the cycle goes back. Usually, you're going to find it a lot in the feces of the cat. This is why cats and the crow, the fat of the cats. This is why any pregnant woman should stay away from any cat or scratch because these are risk factor. Or within the littering of the cats, the problem can be. So any pregnant woman should remove any cat from the house. So the big problem with this is going to give you the congenital toxoplasmosis, this part of the torch syndrome, as you know, and the infection happened the first trimester usually, the first 6 months of pregnancy. And what will be the presentation? The biggest presentation that you need to keep in mind for this one as a keyword is when you do an ultrasound of a fetus, you're going to have calcification in the brain because these become parasite become cystic and they calcified. So this is why this classification found them either in HIV patient or fetuses. The same deal. The only thing is fetus you can do that by ultrasound, as the AIDS patient can do a CT scan with it. All of it. So the other thing is uh, this classification don't see them as just classification in babies, fetus. As the AIDS, you're going to have a ring. You're going to create a ring, um, and the multiple oxidation can happen in AIDS patient with this. Otherwise, in baby, you're going to have triad, which is retinitis um, and hydrocephalus plus intracranial calcification. Um, you might have lymph nodes, but these are going to be pretty much asymptomatic. In healthy patients, the presentation will be different. You might have lymph nodes, but you're going to have flu-like syndrome, and that's it. It's going to stop there. In AIDS patients, once again, multiple oxidation ring that you see in CT scan MRI, and they present themselves. Actually, this is one of the cause to see a physician is the seizure they're going to have, seizure and headache. Uh, so transmission, the number one that you need to know is going to be cats, but it can be also transmitted through the cyst that would be found in the meat of the pork, and this is something that is going to cross the placenta once again. The diagnosis would be biopsy, CT scan, or ultrasound in fetus gave you a big diagnosis just to see calcifications in the brain. You think about toxoplasmosis gondii or ring enhanced lesions. These are pretty much very big keywords. Um, and the treatment, it's sulfadiazine or primetamin, and the primetamin is also used in malaria. So this is one of the presentations that they can give you, but and the parasite. Um, Obviously, you need to know the picture of the parasite, but usually, um, the big picture that they give you is going to be a CT scan of the head or ultrasound of the fetus head. Those are the two big, most common picture for USMLE about it. So, and I showed you multiple times this type of thing. So from the cat, it goes as oocytes, it goes to the feces, and then it goes to the mother and contaminating the baby. And that transmission through the placenta is going to be as a tachyzoids. And otherwise, in animals, it becomes cystic, and it's a cycle. Remember, it goes mostly in the brain of these animals more than anything else. Sometimes I see them in the meat, but you're gonna find them a lot in the brain. So this type of picture as well can be one of the common picture asked. But number one would be CT scan or ultrasound. Number three is going to be this type picture, where you see in the brain. You need to recognize this is the brain, the blood vessel, and glial cells, and you have these parasitic. Here as well, you have the brain, and you have parasites. So once again, same deal, different type of picture. So currently, you can find in muscle, otherwise can go to the brain of the individual. Like I said, if the cycle has been cut, then the mouse is going to be affected by it and goes to the brain and present themselves to the cats. Is pretty much very typical. So these are the enhanced uh, CT scan that you really need to know. In the ring, inside you have the parasites, reachable parasite obviously. Sometimes you see just calcifications. But other than that, ring enhanced. So that is for an HIV patient. Babies, brain calcification, placental calcification. These are for congenital uh, toxoplasmosis. Acanthamoeba. So the acanthamoeba is one of the big problem is going to be the eye. The second problem will be the brain. Actually, one of the type of question that you can have from those are going to be med students that use that did not clean his contact lenses. He was studying and then he put it in contaminated water and then put again the contact lenses and he was affected by it. That is a typical presentation. So that is the eye presentation. Other than that, the presentation can be vary. Um, as the picture goes, yes, they can give you a picture similar to this one with the parasite, but otherwise, it's a presentation of keratitis that they're going to give you. Uh, Worse than keratitis will be the encephalitis, which we call grammatos amoebic encephalitis. It's in Namibia, so it can travel within water and it can be fatal. That is a big problem with it. Other than that, the eye one, the keratitis one, like I said, contamination with the lens will be the topical micronazole as a treatment. Um, Actually, this case, I did present a case like this for the PDI. Uh, it was not in your school. No, I don't think in your school. I didn't do PDI in your school. Uh, yes, so it's a typical presentation, and then they needed to do the diagnosis and they needed to do the treatment beside knowing the detail about the acanthamoeba. Because multiple question for USMLE about this. So the how he present himself as a diagnosis is going to be a star-shaped or spiky cyst on biopsy. The spike in here, spiky cyst, and you recognize a cyst because of wall. There's some calcification that happened, uh, and it's all over the place. So you see here, the infection has been after an implant, and because the normally is supposed to be a healthy water, but it wasn't. You're going to find this type of condition a lot in the Caribbean. Um, and the medical school in Caribbean, a lot of students are affected by it. But I'm giving the students just because it's one of the common questions. But it can be anything. It's not only students. It can be any person, any lens that is in the water, contaminated water, knowing it or not. Um, you need to make diagnosis of it. And remember, even if the cysts are airborne. So you might think that the water is protected and it's not. This is why uh, any solution for the eye treatment or the lens treatment that is not a closed solution, and in a warm water, a warm temperature should be avoided. So other than that, once again, ketoconazole for the brain one with sulfametazine, but usually it's not a good thing. Doesn't work much. This is why it's fatal. As the eye one, you can have blindness happening from it, but otherwise, microdinazole work very well for it. So the contomeba, this is one of picture that you might have, but not necessarily. And from cyst, this is cyst formation with a wall around it. And these are pretty much the resist one. And the biggest question will be the contomeba keratitis from the lenses, which you see the lenses. And lenses will create a red eye. And remember, anything you have red eye is an emergency antiprotodies. Um, so hygiene is super high as a treatment. And remember, any answer for treatment will be prevention, prevention, prevention. And the big issue with the eye is going to abrasion. So risk factor are specifically the people that take corticosteroids, but people that put lenses, those are a higher risk than anybody else. Obviously, the other risk factor are the same as alcohol, drug, chemotherapy, and anything that decrease the immune system are going to be the factor of it. And the presentation is different type of presentations with fever, photophobia, that is when the eye is affected, might have meningitis with neck stiffness, and sometimes they become psychotic. So a psychosis in someone that has a headache with fever uh, and having keratitis, think about and with the risk factor, obviously having a risk factor or not, and putting their lenses in water, suspected water. Those are going to be your big keywords for to make the diagnosis. The Neglia fowleri. So this one is high yield, but not as high yield as the one that we did so far. This one as well, it's an amoebiasis, and is going to present within feces the same thing as any amoebiasis, as a cystic formation, and then you have two cilia. Sometimes they can give you the picture of it, sometimes they don't. But this is something that will attack the brain and meninges, so giving you what you call primary amoebic meningoencephalitis, or the PAM. And big problem, this is why it's asking the board, this one is deadly. It's creating a big inflammation of the brain. So one of the area that is mostly affected would be the frontal lobe. Um, so this is what they're going to have, kind of prefrontal headache, and the smell can be affected as well by it. So keep that in mind: a fever, headache, and smell affection. Think about primary amoebic meningoencephalitis as the case goes. How you get it, and this is one of the think of it, this is a diagnosis that is not going to be done easily. This is a diagnosis of a disease that you can think about anything else besides this. The thing about this type of disease is that this amoeba is going to be in the bottom of the lake or fresh water. And what happened here, the people that are affected by it has been affected by it by accident. Um, and it's if you swim with other people, it's not necessarily that other people are going to be affected by it. Some will be, some will not. And when they get inside this water and they move the mud underneath the lake or the fresh water, this is what the cysts of this amoebic are going to get through the nose and then go through the brain. Um, the death within 1 week, that happened a lot. So this is why you need always to ask the question, if you have someone that has kind of meningitis or headache that you don't particularly know, and it's a summertime, ask if they swim, or look in your case if they swim in this type of fresh water. These cases are not that common, but you need really to make diagnosis about it. Um, so remember that this is why they affect the smell, because the infection will be through the cribriform plate where the affected nerve goes through. Um, so you can find in the CNS the trophozoites. Sometimes you miss it, but in the lab, it's going to look like a bacterial meningitis. This is why I said you can miss it. You can think about bacterial meningitis with the neutrophil, low glucose, high protein, and the treatment will be a bit different from the bacterial meningitis. The treatment here would be the antitrypsin B, and need to be through the by injection through the spinal fluid. But this as well cannot work all the time. So this is why there's other treatments. But keep in mind that actually once we have a case like this, which made the diagnosis, um, and, but the patient died anyway. But there's some patients that recover, and you have consequences for recovery, obviously, because they have meningitis. So the recovery is long, and the consequences can of recovery can take years for it to happen. So this is a very nasty disease and that is the importance about it. And think of it, swimming or jumping in fresh water during summertime. So this is a contamination, fluoride. So you're not it's not high yield. Why? Because you don't have a lot of cases. But within the US, especially where there's a lake, you have time to time 1 or 2 cases a year happening. So think about that. So this is a parasite with a lot of neutrophils surrounding it. And this is the after that we have the frontal lobe that is pretty much affected. the Actually, the thing is the way that you're going to jump in the water. If your head doesn't get inside the water, you don't have, you might not have anything happen. It's the way that they jump inside the water when they have the mud uh, going up. This is where they get. Yes, you need to see your feet, so that don't just jump as you see them doing. And that's, I think, certain area in the world that you have this. So remember, there's a lot of neutrophils. Look like bacterial infection. Frontal lobe inflamed. Adenoma. Destroyed. Here the example. Uh, so why they call it Negliera flori? Yeah, I just remember it as amebia. That's all. But this is a proper bacteria, obviously. When you look at it, see the look like the mouth, the face of the old cartoons, which they did a big thing about them lately. One of the show has been canceled because she mentioned something about this. Remember, right now people are crazy, uh, but it looked like the old cartoon representing the black people, and this goes to the brain. So the GI infection of protozoa. So GI does so many because everything goes through the GI, through water, food, and everything else. So the Giardia noblia, tell me about Stereotica, Cryptosporidium, and Microsporidia. These are the big topic. So Giardia noblia, this is pretty much very common. This has super high yield. This is a you can put it under the travel area, and you recognize this bug. Obviously, this is something that you need to know. It looks like two eyes and a mouth that smile to you. Plus, you have a lot of flagella. So, like all these, I think water will be the or big transmission area. This is why you need either to put chlorine or to boil the water before drinking it. Or now you have these new methods for those who camp a lot, which is the UV light, and that you put in water, and that works as well. Actually, in Anguilla, I was using a lot of this UV light before drinking the water. Um, this is very common once again, and all around the world, wherever there's water, you have contamination. But usually, they will give you the someone that went to Mexico and then has been affected by it. So after 1 week or 2 weeks. Uh, I remember this is bugs that are going to grow within GI itself, and then they're going to use all the food that you eat, and they're going to use it as their own nutrient. Um, and one of the things they are anaerobes, so they hate oxygen. So one of the disease the giardiasis can give you, this is what you call the beaver fever, because you're going to have an attachment to duodenum. Remember the term duodenum as the attachment area, and then you start to have malabsorption. It's not invasive. It's going to stay locally, and a lot of people are going to be without any symptom whatsoever. But the diarrhea, it's smelly, like you ate onion or something like this. So sometimes you might make sure that it's not a melena as well, that because of the smell. You're going to have a lot of gas. You're going to have cramping even. But remember, anyone that went camping, anyone that drink water that was not treated, are going to have the issue. So remember for your case, time frame 1 to 3 weeks after contaminations is when they start to have the problem. Uh, and so this is disease usually that might stay 2 or 3 weeks, but if there's no treatment, it can stay 6 weeks. And remember, it can be transmitted because fecal oral transmission. So people that use the water and defecate in the water, um, you're going to be affected by it. Uh, so remember, they are pretty much resistant as a cyst, and they can stay in the cold water, like the rivers and stuff, for at least 3 months, which will be important to know as information. So obviously, you need to analyze the feces and look at the cyst within the stools, and the treatment. Best treatment is going to be metronidazole if patients do have symptoms. Um, but usually, if the individual is not immunocompromised individual, don't need treatment. It comes and goes as it is. Although metronidazole is best to go. Um, the IgA is one of the way to fight the Giardia infection, specifically for people that do have immunocompromising, like the Bruton disease and CVID disease. These are people that do have a lot of the subconditions. So, what does it mean? It means in your cases, either they're going to give you um, immunocompromised individuals, specifically Bruton and the CVID, or they give you someone that traveled to an area and drink water. This is why if you go to Mexico, it's recommended to buy the water in bottle. So the contamination would be through cyst, mature cyst that goes to the GI, stay in the duodenum, and then it can spread. Obviously, like anything else, like any amoeba, it can spread to the brain. It can spread to the other organs. But that is mostly for people that are. That is for Giardia. The talking about antimicrobial stereotica here. Giardia do not go to the brain. They stay usually in the duodenum. But the antimicrobial stereotica that you're going to look at it mostly as cysts within feces. And this is why I need to look at not this type of picture, but mostly this one. This is one type of picture that can be asked. So the contamination as a cyst goes through the blood, affect the liver, giving you the multiple oxidation, and can go to the brain, give you multiple oxidation, and the lung as well. And the transmission will be through the feces. So you're going to have cysts that are going to uh, give you kind of active infections. So contamination can be happening at any moment. So within colon, you don't have much of colonization, but it can be transmitted through blood in the colon itself, contrary from others. So this is disease that is called as well maybiasis and or dysentery, mostly because of the type of diarrhea that they give you. I remember the Artemia sterotica because it goes to the bloodstream to invade. You're going to have blood within your diarrhea and even pus within your diarrhea, which is characteristic for it, which you don't see much in others, in many others, parasitic infection. Uh, the abscess, like I said, is a very particular abscess. It's kind of whitish type of abscess, and the when you open up, it's going to be that. But from outside, you're going to see it kind of red brown color. But when you open, it's going to be kind of whitish type of color. Um, and the transmission, like I said, fecal oral. Diagnosis, you need to do the feces analysis to see the cyst, and also you might find the RBCs that are in the feces, and these RBCs are particular because they're going to be ingested, um, and inside them you're going to find the amebia. So treatment, like any parasitic flagell or metronidazole, would be the big treatment. Some patients that are symptomatic, you might give them hydroquinone, uh, or can give them paromomycin or dihydroxyquin just to eliminate them. This is a treatment that is good to eliminate all the cysts and kill all the antimicrobial stereotypia and also within the bloodstream and the organs. Never use steroids in this one. Why? And this is the question that you're going to have. Why you don't use that is because risk of perforation are super high. So this is how it look like. I have a center, like a wheel in the center, or like a web, but it look like a wheel. And then this is mostly feces. And this is what you need to remember as big pictures. So liver abscess, the abscess can be pretty much very big in size. And like I said, travelers, and the abscess is going to present can single most commonly or multiple. But the diagnosis is going to be done by clinical presentation. Then you're going to have someone that did travel that start to have a dysentery or the diarrhea and is presenting with the right upper quadrant pain. Other than that, they look like normal. But if you do the lab, you're going to find that they have a big eosinophilic that are high, and the especially so the white cells overall. And the liver function is going to be increased because they have an infection there. So you need to be careful when you do the aspiration. The aspiration is one of the way to eliminate the pus that this is going to be creating. But remember, before doing that, you need to give metronidazole to your patient, and then you do a transabdominal evacuation. But just keep in mind that surgery will be one of the best treatment because you eliminate everything. So here you see the abscess, and which they describe, some describe it as brown. Me, I saw it as white. The pus was white, kind of white, not white like when you bleach something. So cryptosporidium, remember HIV, or anyone that is immunocompromised overall. But commonly it's going to be the HIV. So the diarrhea is pretty much very abundant type of diarrhea. It's so abundant that you might think about cholera, the way that they're going to have it. Uh, it's a water diarrhea, so you don't see much of pus going on. And the other thing, because of contamination, you're going to have a kind of cough without taking the medication they give you the cough. So water diarrhea plus an explained cough is a keyword for you. Immunocompromised individual, HIV, or any immunocompromised is the other keyword for you. Um, and many of the HIV patients do have this disease. So where you're going to find this bug is mostly distal small intestine, and that goes to the respiratory, fecal oral transmission of the cyst, and the diagnosis is going to be acid fast cyst. So it means you're going to look at it like this. This is another acid fast. See, my don't think always tuberculosis. Many actually in the question they're going to answer tuberculosis, um, because obviously HIV patient with diarrhea. But these are acid fast cysts, not bacteria. So while you see them like this in the surface of the mucosa, but the acid fast cysts will be kind of pinkish reddish coloration. So they are typical. So remember the invasion, like in here, see them. So remember this type of picture, and remember this type of picture. These are pictures that might be put. Remember the biggest picture that you have in USMLE beside the X-rays and CT scans are going to be, and if it's histology, is going to be number one would be microbiology type of pictures. Second would be tumors, and then special leukemias, and then the rest. So since it's immunocompromised individual, if it's a normal individual, it's self-limited, don't do much. But immunocompromised, uh, you need to increase their immunity first, and then you are going to treat them with nitrazocyanide, parmomycin. Remember this one, and azithromycin. This one as well. Remember as the treatment of choice. But remember, the treatment will be a long-term treatment until the immune system start to get up and the CD4 need to go up, then they get better. So since this is the first infection that you're going to have, but you can have secondary. So the intestinal cryptosporidiosis versus respiratory cryptosporidiosis. I start as the intestinal, then goes to the respiratory. So the sinus symptoms are going to be, like I said, severe diarrhea for the intestinal, and there's no not much of pus or blood, but you're going to find a lot of mucus. So watery diarrhea, typical. Um, so sometimes be careful because they can throw you away. Sometimes you might find some leukocytes, some blood by irritation, but since it doesn't transmit, or when it goes to respiratory through the GI, then yeah, you can find some blood. Otherwise, not much. And like I said, you need to the differential diagnosis because the diarrhea is so abundant in here. You need to think about the cholera as differential diagnosis, unless there's a tumor. that might give you this type of thing. So malabsorption is big, and hypovolemia as well is big. And these are people that are going to be dehydrated since hypovolemia, fatigue, lost weight because they lose all the water, cramp, low fever is the most important part with the big watery diarrhea. Sometimes you might have vomiting as well with it, and abdominal pain might be very. The other signs that you might have, and usually are the involvement, you might have an ascites, and if you see an ascites, it means that the pancreas has been involved. If you see a jaundice, that is the hepatobiliary tract that has been involved, and if you see reactive arthritis, uh, that differential diagnosis will be rheumatoid arthritis usually, and that is because symptom like flu-like syndrome. In respiratory, the big keyword, like I mentioned earlier, would be an unexplained cough in someone that is immunocompromised with uh, big diarrhea. Uh, so here, when it involves the respiratory, is going to be pretty much inflammatory process that is going to happen. You might have what looks like a flu because they have nasal discharge. The voice start to change portions of the voice, but it's mostly the cough that lead them to short breath and and fever. Macrosporidia. This one as well is kind of high yield, and you need to make the differentiation with cryptococcus as well, um, because if they have spores, I can hear it's going to be acid fast. Other than that, these are gram positive type of parasites. So you're going to see them invading the mucosa, intracellular. If we're going to, there's not much of treatment because it's intracellular, but these are seen in HIV patients a lot, or immunocompromised patients. And see here in the mucosa within the intestine, you're going to have a lot of neutrophils that comes over. The typical is going to be intracellular invasion. Keep this one in mind, or this type of picture, because of the acid fast spore. So presentation is going to be severe diarrhea. So in this case, we have a 10 years old male present at a general hospital in Nepal with a 6-week history of fever, diarrhea, abdominal pain, and weight loss. He had previously been treated with antibiotics and antimalarial with poor response to treatment. Physical exam revealed a patient with conjunctival pallor and generalized lymphadenopathy, as well as hepatosplenomegaly. Complete blood count reveals hematocrit 21%, white 3,000, almost 4,000, platelets 95,000. That is significant. And the chest X-ray normal, bone marrow aspiration, intracellular amastigotes in the macrophages as well as extracellular amastigote. That is significant. So you have hepatosplenomegaly with the super big spleen. And the keyword can be Nepal, but fever, diarrhea, no pain. That is mostly the spleen that with thrombocytopenia that is significant. So this is what you call the Leishmania donovani. This one as well is a high yield type of a question, and your keyword obviously is going to be the once again splenomegaly. So you're going to have two type of this Leishmania donovani, the cutaneous one and the visceral one. So it's pretty much as well intracellular type of infection. Keep that in mind because treatments, and they're going to have some kind of flagella when otherwise it's going to be mostly cystic. So if it's the visceral one, this is what you call the calazar. And the typical presentation or typical thing is people that or kids that play in the water that does not move much. You see this a lot in Egypt and Africa or Asia. So what you're going to have is a fever that is going to be a spiking fever. So it comes and goes, but you have the spike. And once again, the hepatosplenomegaly, especially the spleen, is super big spleen. This is one of the disease after lymphoma that is going to give you super big, huge spleen. Um, and the pancytopenia. This is why he has low white cells. You think that the white cells are not reactive? No, because this disease is associated with pancytopenia. And the one value that we notice pancytopenia is going to be mostly the platelets. This is what you ask yourself: is not pancytopenia or what? Um, these are kids that not much nourish and sometimes be careful can be fatal type of conditions. So one of the transmission, like I said, is going to be the continuous one would be the sandfly. In carousel, you didn't have much of sandfly, but in Anguilla, yes. And it's humans are reservoir, wild animals as well. So all these are going to be continuous. So otherwise, visceral is going to be the water. Uh, so diagnosis, you're going to find the flagella-lacking form, amastigotes, that are inside the macrophages. I can hear the macrophages, see them inside. Macrophages, and see them inside. So these are not cysts, okay? And this is a blood smear. So the treatment of choice um, is going to be sodium sibogluconate, and remember this is one of treatment that is super tested in step one, and so remember that. And amphotericin B or fluconazole used more commonly, but it's not testable. So if they give you this disease or they give you a treatment, they give you mostly the sodium sibulogronate more than amphotericin B or fluconazole. But remember, they can be testable, but you don't see much of question about them. That's the thing. So this one is also a cutaneous one with perfections. Look at the heads, and this one is a visceral one, and this is within the bone. So this is the cutaneous one. You see ulceration at the beginning, a big hollow around it. It looked like actually a venous stasis. They give you a venous ulceration, but it looked like as well squamous cell carcinoma. So be careful if you see it in elderly, because one of the differential diagnosis is going to be uh, squamous cell carcinoma or basal cell carcinoma. The only thing is you're going to see a granuloma all over it. So the cutaneous one sometimes is when they become diffuse, you're going to call it lupioid leishmanias, which look like lupus that invade the whole body. Some of it come back, leishmanias recidiva. Otherwise, you're going to have the Tropica mexicana, Brazilians. All these are cutaneous or mucocutaneous type of action. So this is why you need to know which one give you musculocutaneous, which one give you cutaneous, which one will give you the visceral. So the visceral one are going to be the most common one with the cutaneous one. So Leishmania donovani are going to be the biggest one. You can have the Chagas as well, but for the step would be Leishmania donovani number one. And for the cutaneous one will be the Tropica or the major one that would be cutaneous more commonly. Otherwise, the mucocutaneous one, this one is easy to remember because from Brazil. Otherwise, the one that you must know is Leishmania donovani for the visceral leishmania. So this as well can be questions, and so this is the sand flies. Actually, on the bite you, they give you yes, most commonly in the sand or in the dry dirt. Um, and when they bite you, it looks like an allergy that you have. So it's pretty much very itchy. But you need to remember as well in here that the bodies, what you call the bodies of the Leishmania donovani bodies, uh, and this is what when you do your diagnosis, you might see them within the preparation of the blood when you do the aspiration or the bone marrow as well. And if you see this or lymph nodes biopsy, if you see this, you know that you're dealing with Donovani bodies. Um, the cutaneous one, usually you're going to use gem sustain and to make to prevent intracellular the amastigotes that are within macrophages, and uh, and then you do a scripture of it. So these are the flies, and this is what happened after the breathing. And pretty nasty. So the sunfly is going to be a cycle. Usually, you're going to have a cystic formation with what you call the promastigotes that become amastigotes after the release, and this is how they become. They infect the blood after the release. This is the amastigotes form. You have flagella, and when the fly bites you, goes to the blood, and this is how contamination is going to happen. Other than that, the contamination from sandfly can go from animals, and human is just in the middle of all this. So remember that humans usually are affected by the amastigotes form, and the dogs you can have the phantom, and the animals usually phantom. The one that I showed you earlier, giving you the visceral type of leishmania. So in this case, you have a 43 years old man that presents with 1 week history of fever, myalgia, chills, and night sweat. He just returned from a business trip to Africa and the Middle East. He received the relevant immunization prior to the trip and was on prophylaxis uh, throughout. His temperature is 103 and he's diaphoretic. And on the physical exam, there's a mild splenomegaly, but no stiff neck and photophobia or lymphadenopathy. Pair of smear is what you see. So you see red cells and stuff inside them. So this is one of the nastiest diseases as well, especially the type of fever that you're going to have and the pain that they're going to suffer from. So this is a plasmodium, which would give you the malaria. So you have two diseases from this. This is a hematological type of infection, but you have the plasmodium itself and you have the babesia that can come from the disease. So the malaria, the big problem with this is the fever. Like I said, it's a fever that is cyclic and the will come back every 72 hours, 48 to 72 hours. It's a very big fever where you might think about lymphoma or tuberculosis because of the type of when they have fever with the shaking, you have a lot of sweating, uh, soaking type of sweating, which is very characteristic. This is why you need to look at the three the differential diagnosis. The only difference in here, you know that this individual is within a contaminated area, so you think about malaria first. Other than that, and there's no much of, you might have splenomegaly, but the big thing is going to be anemia caused by hemolysis of the blood of the red cells. The other big problem is going to be hemorrhage and ischemia within the capillary venule, and you're going to find that all over the body. So, Plasmodium has two hosts and need to perform. They're going to have human host, which will be the most important one, and the human host is going to be during their asexual phase of the cycle. So why they have hemolysis is because the parasite get inside the red cells, and once it get there, it's going to be comfy and create the hemolysis. This is why the red cells start to change in shape and become sickle, and that is the evolution of this disease in Africa. And when they become sickle, there's no space for the parasite to get inside. But otherwise, if they don't have sickle cells, if the red cells are normal, um, you're going to have multiple phase. How you're going to have it, especially in liver, and this is what you call the exoerythrocyte stage. So at this stage, you're going to have sporozoites, which are this is where they're going to be motile. You're going to have them as a spindle shape, which you might see not here, spindle shapes. And this is the start to invade the liver, parenchyma. Then they become trophozoites. And trophozoites within the hepatocyte, they become like a ball and they start to divide. When they start to divide, they become schistones, and you're going to have all these cells that are going to be a lot of. It looks like the cell to have a lot of nuclei because they are uh, baby plasmodium. Then they become merozoites, and that is where they have the cytoplasm nucleus, and they start to lyse the cells, the liver cells, and start to invade the blood. Once they start to invade the blood, then they're going to start to invade the red cells. Remember that malaria is transmitted mostly by mosquitoes, and the mosquito is going to, through oocytes, they're going to inject it towards the body. Then the first thing area would be the liver, and then red cells, and from the red cells they start to multiply easily and move around easily. And when the mosquito bite again, then they will take these zygotes and they're going to really transmit them to others. So Plasmodium falciparum is the malaria one, and this is what I was explaining. And remember that you're going to have two type of gametes for this male and female, and they're going to multiply, and this is how the transmission is going to be done. And remember as well that the Plasmodium, there are multiple type. The falciparum, this is one type, but the other type can be the Vivax, the Ovale, and the Malaria, the one that give you malaria. But the cycle is going to be almost the same. So then, after the liver, it goes, like I said, in the red cell. This is what you call the erythrocyte stage. And they're going to do the same thing as it was in the liver until it creates the hemolysis of the red cells. Uh, just remember, as the question would go, that the Vivex1 and the Ovale one, see them inside here, the red cells, and here after rupture of the red cells. So just remember the Vivex and the Ovale one are going to produce hapnozoids, which is the dormant form that are going to stay in the liver for a while until they wake up. And this is why many of the people, so the Vivex and Ovale, many of the people are going to have again the malaria after a few years because the dormant ones start to wake up. Uh, and this is one of the reason, and this can be a question for USMLE. This is one of the reason people that did have malaria once in their life cannot give blood. Why? Because they can have them as a dormant, and we never know what can happen. Uh, so you see them in here. You see all the eggs, looking like the eggs. These are the ones that are pretty much in the Merozoic form before rupturing. So around the world, still, even in our days, there's so many cases. In the Caribbean as well, there's so many cases of this condition. So the question as well. This is one of the beside the tsetse and the kissing bug. Um, this is one of the mosquito that you need to know. With also the other mosquito that you need to know are the one that give you the what do you call it? The chikungunya and the latest one that give the dengue. Yeah, but mostly chikungunya and the what do you call it? Because they're the same type of fly. They are zebra type of mosquitoes almost. Um, West Nile, yes. So there's few of them that you need to know the mosquito itself. This one is one of the old common questions for the USMLE. This is something that has been asked in all medical questions, either for board or not board, because of the frequency of this disease and the trying to exterminate this type of mosquitoes. So these are the Anopheles mosquitoes, and the malaria is going to be in the sexual phase of this. Remember, you have male and female. So in the Anophel, this is where you're going to have the gametocytes that are in with the new humans, and they start to change to male and female, and these are going to be taken up by the Anopheles mosquitoes and given elsewhere. So male and female, once they start to fuse in the stomach of the mosquito, this is where they form the oocytes. And then the sporozoids, this one is where the oocytes start to divide and they start to be able to be injected in human to start new cycle. And see here, in this mosquito, you have feces coming up. And then you're going to have the typical lysis of the red cells, etc., that you know. Sometimes you might have, because of hemolysis and jaundice, these people. But you see here that it's not. There's no zebra, there's no striation. They're brown. The wings are pretty much very small, and uh, and also remember the one of the things that you can need to be proven for me. But it seems that the malaria mosquitoes or the Anopheles usually bite in the feet. If you have bitten in the feet, you know it's mostly Anopheles. If you bitten elsewhere, it's not malaria. Um, this is how I've been taught in infectious disease long, long time ago. So you don't feel anything when they bite you, it's true. So here you see the different stages within the RBCs. Here, this is the merozoite type of stage and ready to erupt and starting to invade. Well, see the parasite. This is pretty much big one, and this is why when you have sickle cells, they don't have any space anymore, so they cannot invade whatsoever. Plasmodium falciparum, it can be deadly, as you know, and the other disease that they can give is the black water fever. And this is the difference, and this you need to remember it because these are emergency type of infectious disease. The black water fever are going to be the presentation of the malaria, but you're going to have renal failure plus a big jaundice with it. And that is, if you see that, you know your diagnosis. So here as well, invasion. This is schizonts. within the erythrocytes. But this is one of the oldest picture of the evolution of your malaria within the red cells, how they present themselves until you have the female and the male gametes. So we don't need to know the specificity about that. That is mostly in school question that you might have this. Otherwise, for the board, you need to know just the cycle that you're going to have. So between all these four type of plasmodium, remember the falciparum one is the most deadliest one. Can kill, like I showed you with the Black River syndrome. It can be kind of cold, and this is very common also, the falciparum, Mediterranean tertian malaria. And how you recognize it is the spike, which you're going to have every 36 to 48 hours, a spike of temperature with chills and sweating. Um, the problem is when you have lysis RBCs that happen in the brain. This is what you call the cerebral malaria. Uh, but remember, once again, which is microbiology type of questions, the falciparum one do not have haplozoic stage. So the Vivex and ovale, this one is benign. It's kind of tertian type, and you're going to have 48 hours fever spike. Uh, why they call it tertian is because you have one day and day three. Uh, so it means that the fever is going to be only for 48 hours apart between day one. So day one there's nothing, and then you have 2 days fever, and then you have nothing 3 days, and then you have another. So this is why it's tertian. In this situation, you have in this type of virus and ovary, you have the apnozoid stage. The malarian one, this is quarter malaria, and that is because of 4 days, 72 hours fever spike. So the first one is 48, 36 to 48. Second one is going to be 2 days, 48 hours between day one and day three. And the malarian one is going to be 72 hours spike fever. So pattern, 4 days. Um, the remember the in the malaria one, what happened? Why is happening this way is because which you call the recrudescence, is because every time you have hemolysis and the release of the plasmodium, this is where you have the spike of fever. So that is immune reactions. So remember as well in here, the malaria one, you don't have hapnozoid stage. That is to remember. So see them here at different stage. So these dots that you see, especially in here you don't see them. But here, especially for the Vivax one, this dot that you see, this is what you call the Schaffner's dots. I remember this one because if they ask you that, it means they're talking about the Vivax one, Plasmodium vivax, but not the malaria one. Like here, you see them as well, the ovale, you see the Schaffner's dots. So once again, the temperature here would be very important. 36 to 48, uh, 48 hours falciparum, and then better, and then spike again, 3 days. And then you're going to have the first day, and then the third day, spike. So that is the tertian. And then you have the malarian, the first day, and then 4 days, spike. So 72 hours. So this is why they call them the paroxysmal fever, because come and goes. But once again, that all these fever are associated with high type of fever, and sweating, 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 sweating. A lot of it. And sometimes you might have shivering before happening, and shivering tell you that he's going to have start to have fever at that time. So this is the best time actually to make to do a hemocult to see the bugs. So the diagnosis obviously is a blood smear. Need to look the RBCs and you need to look inside them. There's another test that can be done, which is the antigenic test, rapid antigenic test. But the thing is, this one is pretty much very expensive for Africa for now. Otherwise, the prevention is one of the biggest treatment in here, and you're going to see it in all the CDC pages and all the preventive pages in the medical field about this disease that is killing mosquitoes and putting the net around the beds and long sleeve in areas that are affected and the repellent, um, especially for the travelers. As immunity goes, remember long term will give you sickle cell threat that is typical preventive in genetic with time. And remember that anyone, this is the ABS, hemoglobin S, obviously. And remember in this situation, the antigen that will be missing for our BCs, and remember it for hematology, this one, is the absence of the Duffy antigens. And the absence of Duffy antigens, this is what prevent or protect against the Vivax. And so you're going to see if you check this type of antigen in anyone that come from Africa, from north or south of Africa, middle of Africa, they don't have it. And that is one of the genetic traits. Otherwise, drugs, chloroquine is so far one of the best drugs. Chloroquine, primaquine, and if you uh, have a resistance, chloroquine resistance, you're going to use the mifloquine, quinin, the altimeter, the atavocon, etc. Um, and one of the questions that has been asked for treatment was about the pyrimethamine, sulfadoxine, and that the action of this medication is it's a reductase inhibitors that is going to be used as well in toxoplasmosis. So the chloroquine, this one killed the RBCs, so it means killing the plasmodium. So for very sensitive for the Vivax, ovale, and malaria. And but the falciparum is going to be pretty much resistant to chloroquine, so I use the other one. But remember, this is another question for pharmacology. That chloroquine give you retinopathy in long-term use. Primaquine, this one is for Vivax and ovale that will kill the apnozoids, and then we saw for the falciparum. Okay, I think we're going to stop here today and tomorrow give you time to review all this and know all this. And tomorrow we'll finish the parasite and start the mycosis. And at 10, we do question like today. I'm going to slam you again with the questions. Okay, perfect. Very good. So, my dear